Hello, everyone, and welcome to McGill Cares webcast series supporting family and informal caregivers. I'm Claire Webster, a former caregiver, certified dementia care consultant, and founder of McGill University's Dementia Education Program. I work with a dynamic team of leading healthcare professionals to oversee the program, who include Dr. José Moret from the Division of Geriatric Medicine and Dr. Serge Gauthier, Professor Emeritus, formerly of the McGill University Research Center for Studies in Aging. McGill Cares is supported by the Amelia Saputo Community Outreach for Dementia Care. The McGill Dementia Education Program offers a comprehensive range of free resources to educate and support persons living with dementia, family and informal caregivers, healthcare professionals, medical students, and the public at large. One of our most important resources is our Dementia Companion Guide, which is currently available in 14 languages and many more to come, and it can be downloaded for free. And printed copies are available on Amazon at a cost of $20, which it goes to support our program. We also have online education modules, virtual support groups, so please take the time to consult our website to see what is available for you. So today I am very excited to be able to have the topic of understanding behavioral and psychological symptoms of dementia. It is a request that comes in very often to our program of viewers who would like to learn a lot more about this topic. And I am very pleased to have one of the leading experts in Quebec who specializes in this topic. So with me is Carmen Desjardins. She is the program manager of the Dementia and Psychiatric Comorbidities program at the Douglas Research Institute. She was the chief and founder of the Behavioral and Psychological Symptoms of Dementia ambulatory team of the Montreal West Island Integrated University Health and Social Services Center. And she has been involved in implementing their Alzheimer's plan and is a member of the panel of experts who develop MSSS guidelines for treating these behavioral symptoms for the Center of Excellence on Longevity. So welcome, Carmen, to McGill Cares.
Hello, Claire. Thank you for having me.
So we have a lot to talk about today, a lot. So I think just to begin, I'd like to get give my viewers a chance to get to know you. If you could just tell us a little bit about your background in the healthcare system, and then maybe just set the setting of the Mo-Levin unit where you work.
So I'm a clinician nurse by profession. I started working with dementia patients probably about 20 years ago, with dementia patients as well as their caregivers. As you said, I am now chief of the dementia program for the Douglas Institute, the Mo-Levin. And I'll talk to you a bit about the services that I manage. So we have three services under my program. We have the memory clinic, and the memory clinic is a clinic where we receive patients that have subjective complaints that are referred by their GPs, and they come to us for an evaluation of their cognitive functions, for validation of diagnostic if there is one. We also put together the treatment plan, whether it be pharmaceutical or just resources. We support them, we give them a lot of teaching, and once the condition with the patient is stable, we can refer them back to their GP, and they take over with the patient. We also have a therapeutic day center. In our day center, we offer three programs. We offer a program called CIUSSS, which is a remediation program for people that don't yet have diagnostic of cognitive decline. However, they do have subjective complaints that they have memory losses. We also have our other program, which is Neuron en Action, for people that have just been diagnosed with dementia, and it gives them stimulation exercises. And we have a third program that we just started, which is Synapse en Action. It's a combination of both because we've realized that some aren't advanced enough and some need a bit of remediation as well as stimulation in combination. So that is our therapeutic day center. And then we have my baby, the Mo-Levin. The Mo-Levin is a unit. It's a unit where we admit patients with very, very severe dementia, and they have severe SCPDs. Actually, in English, it would be
behavioral and psychological symptoms.
Exactly. So
yeah.
I'm trying to switch from French to English, to Claire. But so my unit is for people with severe behavioral disturbances related to dementia. We have a small unit. It's a 12-unit. It's a 12-bed unit. It receives the patients that have probably the most severe behavioral disturbances on the island of Montreal. So by the time they come to me, usually they have already seen a geriatrician, a psychiatrist. They have had the SCP, the ambulatory team that has gone by. They have had tried medications. They're usually extremely aggressive. They hurt themselves. They hurt other people. And basically, the Moldovine is the last stop. So when we receive them on our units, what we try to do is we try to really step back, observe, and try and find non-pharmacological as well as pharmacological interventions that we could put into place to help them. And usually, I would say in most of our cases, we're actually able to send them back to where they come from. And they're fairly stable without being over-medicated. So we really, really try to bring forth non-pharmaceutical and pharmaceutical, but to stabilize them enough to be able to go back home.
So just to clarify for the people watching, so the Moldovine Center, it's not a private residence. So
it's not a private residence.
So how, like if somebody's listening and say, well, how, I really feel that my loved one needs to be admitted to your unit, what's the process to do that?
So this is where it gets a little, it's not complicated, but we usually don't take people from the home. And the reason for that is usually by the time a patient comes to the Moldovine, it's because he's extremely, extremely severe in his dementia as well as his behavioral symptoms. So technically, he should have gone through other evaluations before coming to a third line unit. He should have gone through the first line, through a CIUSSS, through a social worker, through an ambulatory team. He should have been evaluated at a general hospital in order to eliminate any infection or any physical cause behind his severe behaviors. So usually the patients that I get are from CIUSSS, or they're from RIs, which is the résidence intermédiaire, or sometimes straight from the hospital, because the CIUSSS will send their patients to the emergency at the general hospital. They will do a full medical examination to clear the patient, and then the hospital will refer them to us.
Okay, that makes sense. Yeah, thank you for clarifying that. So many people think that when you hear the word dementia, it means memory loss. And what many people don't realize is that dementia can cause, changes in a person's behavior, personality, a lot of things. So can you provide some examples of what we call, responsive or these challenging behaviors that are caused by dementia?
So I'm gonna first start by clarifying the word dementia, because like you said, most people think that dementia means memory loss. But dementia is actually the big title. It encompasses so many different types of memory losses or so many types of dementias. It's just like cancer. You have different types of cancer. You have lung cancer. You have breast cancer, brain cancer. Dementia, you'll have Alzheimer's, you can have vascular, you could have mixed, you could have Lewy body, you could have frontotemporal. So right off the bat, we have different types of dementia. And depending on the type of dementia, we'll have different behaviors, right? So some behaviors will be more towards a certain type of dementia. For instance, if we have Lewy body, we'll have more hallucinations. If we have Alzheimer's, we'll have more memory, more self-awareness disruptions, so judgment, right? So depending on the dementia type, we'll have different behaviors. So when we're thinking about dementia behaviors, we think of 4 clusters. We'll think of non-aggressive behaviors, which are non-aggressive verbal behaviors, for instance. So you can have echolalia, somebody who's always repeating the same thing. You could have people that ask questions over and over and over again. People that speak continuously, that they never stop speaking. And actually, these behaviors are very, very challenging for the caregivers, because you can imagine somebody who's always asking the same question. And although that might not be physical aggressiveness, it might be very, very aggressive.
Energy draining.
energy draining for the caregiver. It's very hard for them to have that repetitiveness. So you have that type of non-aggressive behaviors. You have the physical non-aggressive behaviors. It can be very challenging as well. So you have the wandering, the pacing, moving objects, the hoarding, the scab picking. So these are all non-aggressive behaviors that could also be very challenging for the caregivers. And then you have the aggressive behaviors. So you can have the aggressive verbal behaviors, which will be more swearing, yelling, but on an aggressive tone, sexual disinhibition. So with words, that is also a form of aggressive verbal behavior. And then you'll have the physical aggressive behaviors, which are kicking objects, throwing objects, punching walls, pinching, scratching, spitting, grabbing by hair. So you have all of those physical aggressive behaviors as well that you can find in dementia. And you also have the perceptual disturbances, which will be the hallucinations. So they see something and they truly believe that that thing is there. So we have to be careful with the way that we speak to them about their hallucinations, because they truly believe that what they see is there. And then you have the delusions. So you have the paranoid delusions and you have the persecutory delusions, where they think that somebody's out to get them, somebody wants to hurt them, or that people are stealing their things. So those are also behaviorals. And then added to that, you can have apathy. So they have this loss of reaction in their facial expressions. And that could be challenging for the caregiver as well, because the caregiver tries to do activities with their loved ones, but the loved one doesn't react. And so that's the type of behavior that can be challenging, because they feel like they're not doing anything to help them. But in reality, the fact that they're not reacting doesn't mean that they're not enjoying the activity. It's just an apathy that sets in with the dementia. You have the anxiety. So you can imagine that somebody with anxiety, his stress tolerance is much lower than somebody that has normal cognitive functions. So when they become anxious, it's a behavioral disturbance, because they might hyperventilate, they might start pacing more, they might start having more wandering. So there's that anxiety. And then there's also signs of depression. So they can have depression. And that's a behavior as well that you can sometimes see in dementia.
So it's really amazing, because there's such a lack of public awareness education about these symptoms in dementia, right? So a lot of times families won't really know what professional to consult. Like you say, for example, the depression. I remember my mother, one of her early signs was depression. So you're saying to yourself, should we go see a psychologist? Like, who do you see, right?
Yeah.
So what is, I mean, the journey to getting a diagnosis is not very clear, right? Because a lot of people, the first stop is their family doctor, or some people don't even have a family doctor. That's another challenge right now. What is the road to getting a proper assessment, especially for somebody who has these behavior issues?
It's unfortunate, because it's so complex and it could be so easy. And when we're speaking about behaviors, we can't ignore the anosognosia, right? So we're actually trying to get our loved one to have an evaluation for their cognitive functions, but they don't even realize that they have memory problems. And when you try to get them to the doctor, they'll be like, there's nothing wrong with me. I don't want to go see the doctor. I don't need to get my memory evaluated. And they completely refuse to go. So that's an entire other issue.
That's
However,
probably the biggest challenge, right? I mean, which most of the families I work with see, that anosognosia, where they're totally loss of insight, right? They refuse to go to the doctor.
they completely refuse to go to the doctor. However, what we can keep on our sides to help us is that generation, there's God and then there's the doctor.
Yeah.
Right? So if you can get them in the doctor's office and have the doctor do an evaluation and prescribe evaluations, then you have one foot in the door. But you have to get them to the doctor. So I guess one of the ways to do it is just to maybe ask your loved one if you'd like to go for his yearly annual rendezvous with you.
Yeah,
and you go
together,
right? So there's that. So you can go two routes. So you can go through your GP. If you actually get your loved one to your GP's office, they can do an evaluation of cognitive functions if it's a typical presentation. So if you have a typical presentation where there's a slow loss of functioning during their daily living, you can see that there's word searching, they're repeating more, they're a little bit more disorganized, then you know that it's probably a typical presentation. You can go to your GP, they can do an assessment, they do psychometric testing, they ask all kinds of questions, and they can actually diagnose with that information. However, if it's a little bit more complicated, where it becomes atypical, so it's an atypical presentation, you have people that are much younger. We're seeing a lot much younger people these days that are presenting with cognitive decline. So they're losing functioning. They're a little bit more disorganized during their activities during the day. They have delusions. They might have hallucinations, but there's no memory loss, and they have no history of psychiatric mental health problems. So these are the patients that you should ask for a consult from your GP to a third-line service, or to a neurologist, to a geriatrician, or to a psychogeriatrician. So that's where it's a little bit more complicated. You might need extra testing, an FDG PET, you might need a lumbar puncture, you might need more testing for that clientele.
Okay.
Does it make sense?
Yeah, absolutely. Because sometimes it also could be another health issue that could be presenting these symptoms, right? You really need to investigate, because sometimes it's very clear that, okay, the person has these memory issues, or, but sometimes it's not clear. And I think, just to add on that, what I try to always recommend to people that I'm working with is, in order for a proper assessment to be made, the doctor really needs the feedback from the family, right? Like, you really need, the family has to write down, like, what are the changes? What are the behavioral changes? Like, as much information as possible. And I always recommend to send that list ahead of the appointment, because the person who has the anosognosia and doesn't want to be there, it's very hard to be sitting with your mother or your husband or your wife talking about them in front of the doctor when they don't believe anything is wrong.
Yeah, 100%, 100%. As a matter of fact, at the memory clinic, when we usually assess a patient, we usually ask that the caregiver be with them, whether it be their children, their wife, husband, spouse. We ask that they be with us in order to confirm a lot of it, because, like you said, you ask questions to the patient and everything's fine. No, I don't have any problems with my memory. I don't have any problems cooking. No, I don't. There's no problem whatsoever. And so normally it's good to have the patient, you let them talk, you ask them questions, you let them express themselves. And then afterwards, you meet with the family member in order for them to validate the information that was given. Because you also want to evaluate the insight, right? So you want to evaluate the insight of the patient and their judgment, which is something that you can't evaluate if somebody isn't there to validate.
Exactly. So let's talk about, like, what are some of what is causing some of these behaviors? I mean, we know that, for example, as dementia progresses, the person will lose their ability to communicate. So it would be much more difficult for them to verbalize if they're in pain or they need. But so talk to us about what are some of these causes, and then perhaps I will even merge my next question is, are there certain triggers also that exist that could cause these behaviors?
So that's a very good question. And that's why dementia care is so specialized, because it's so difficult to pinpoint the reasons why there are challenging behaviors. And I would have to say that 90% of all challenging behaviors are usually caused by unmet needs. Mm-hmm. So it's usually, I would say, I'm not talking about the clientele that I have at the Montreal, because that is less than 1% of all of patients that suffer of dementia. I'm really speaking of the people that have light to moderate dementia, that are still at home, but that are starting to have behavioral disturbances. So usually it's more unmet needs, and it could be environmental. And when I speak about unmet needs, we have to really break down what these needs are, and these are things that we seem to forget. So there's the physiological needs that need to be met. Are they thirsty? Are they hungry? Are they cold? Are they warm? Do they have to go to the washroom? And this is one need that a lot of people forget, that people that have dementia cannot express that they need to go to the bathroom or they can't find the bathroom, but they feel the discomfort and they might act out. So that is one of the needs that is often not met. There's a safety needs. So we all have safety needs. So if you can imagine somebody who doesn't recognize the people around them, they don't recognize their environment, they have anxiety, they're feeling scared. So that is their safety needs that are unmet. So a lot of times there needs to be validation, they need to be reassured. You also have these self-esteem needs. So these are people that have histories, they have a past. And so they need to have that loving, they need to have the attention, the caring, the validation. They need to feel like they're still part of a community. And a lot of these things are forgotten with people with dementia. We seem to put them on the side and we tend to their immediate, what we need to do for them right now, but we forget them as a whole person. We forget that they used to be a human being before the dementia. And then there's a self-realization. These are people that have had jobs, they've had worked, they've had careers. And so we need to give them activities. We need to give them things to do to make them feel like they're still worth something. So if you break it down and you look at the needs that are not met, we're looking at physical, we're looking at loneliness, we're looking at feeling like you belong somewhere, a feeling of, so there's so many needs that we have to look at. And I think that when we fail to think of these needs is when we fail to find strategies to address the behavior that they're showing.
And what about triggers? So, you talked a bit about, the environmental aspects. And, I'll give an example where, my mother, even in the earlier stages, as soon as we took her to a crowded place, okay, so whether that be a shopping center, a restaurant, an airport, somewhere where she used to be comfortable, that triggered her to have tremendous anxiety. Okay, it was like the sounds, she couldn't understand, right? So what would be some more other examples? Like what could trigger challenging behaviors to happen?
So many things could trigger. There's as many triggers as there are people with dementia. There could be millions of triggers because every single patient with dementia has a history. They have a personality. They have baggage. We have to know where they come from. We need to know what they feared when they were younger, what they hated doing, what they loved doing. It could be lights, it could be noise, it could be certain people. And unfortunately, because of the generation, it could be race, it could be anything. It could be anything. I had a patient who didn't want to take a shower because she was part of the concentration camps. And when we brought her in the shower, she thought we were bringing her in, so it was traumatic for her. It was horrible. We have patients that have had sexual abuse when they were younger and we don't know about it, but then we try and do hygiene care and they become completely disorganized and very aggressive. But what we need to understand is they don't know who we are and they think that we're aggressing them. So these are all little things that we really have to take into consideration when we take care of patients that have dementia and their triggers. And I think that one of the only ways that we can look at the triggers and act on them is to really try and break it down. So you need to break the trigger down. So you need to have a hypothesis as to what is underlying these agitated behaviors. What is it? What do you think? Look at it, study it, sit back, think about it, introspect. Why does she act like that today? What was going on around her that might have triggered something? What was the unmet need at that moment? Is it because she was in somewhere that was too big? There was too many people. She felt like she was lost. She felt like she was overwhelmed with all this space, too much stimuli. So what is it? What is the cause that is causing the behavior? And the thing is, we have to stop trying to address the behavior directly. We need to address the cause, right? And so what is the behavior? Is the behavior expressing discomfort? Is the behavior expressing fear? Is the behavior expressing solitude? What is the behavior expressing? That's what we need to act on. Does it make sense?
Yeah, and I see a lot, I find that oftentimes families have a really hard time of letting go of who the person was and embracing who they're becoming, which for an example is, that person that every Sunday you'd have the whole big family gathering and all the kids running around, the dogs barking, but maybe that person just can't manage that type of social situation anymore. But then the family says, well, we've always done this, or we've always traveled, or we always did it. So
Yeah.
you try to say, okay, well, maybe that's not what the person can manage anymore, right? So it's up to the family to really evolve and not force that person to be continuing to put them in a situation where they're uncomfortable.
So, and I say that often to family members and people that I train, is that it's interesting how we expect somebody with cognitive disorder to adapt themselves to us
Mhm.
when they don't have the cognitive capacity to adapt themselves to us anymore. They just don't, right? And that's what we expect from them. However, we need to adapt to them. It is our job, it is our duty as a person with cognitive functions that are not attained, that are not disrupted. I'm thinking in French there, to address the behaviors and to help them, right? So we really need to learn how to analyze the situation. We need to look at what was the behavior, when did it happen. Was it in the morning? Was it in the afternoon? Was it in the evening? In what surrounding? In what environment? Was there a lot of people? Was there no people? Were there strangers? A lot of noise? So we need to really address all of these questions and then try and adapt our treatment plan to respond to their needs, right? Because somebody who has dementia, like you said, who's in an environment where there's a lot of noise and a lot of people speaking, they can't capture all the words that are being said. So for them, it's just like, I always think of, like, remember Snoopy? Remember Snoopy when they go in the class and there's the teacher in the front that goes wah 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 wah. So I'm thinking these dementia patients are looking at people talking and it's just a muffle of noise around them and they can't hold on to anything that's being said. And so it gives them all of these feelings of, I'm not being heard, I'm not being seen, I'm scared, I have anxiety, I don't belong, and for sure they're going to act up.
So that just goes right nicely to my next question. So what are some of the most common mistakes to avoid when interacting with someone experiencing these behaviors? I'll say number one is like getting into arguments, right? Like we see couples arguing all the time because of that anosognosia. People spend so much time trying to prove a point or not realizing the person really lacks that insight, right? So what are those mistakes to try to
So, so we have to show insight.
yeah.
So we have to show insight and we have to stop acting on the behavior. So we jump on the behavior. So we have to stop jumping on the behavior and we have to start thinking about what the cause is, right? I'll give you an example. A patient that has dementia, has something in their hands, a paper that you don't want them having in their hands because they're an important paper. Instead of going up to the patient saying, oh, no, touche pas, give me that paper, and taking the paper out of their hands, well, of course they're going to jump. They're going to pull on the paper because they don't understand why they can't have the paper. Instead of doing that, you think, what is the need? He needs to do something with his hands. He needs to have papers in his hands. You find something that might be of interest to him, and you go to him and you offer him, I have this book that I'm working on. Can you help me with it? And you hand it to them. Normally they'll pick it up and they'll let the other thing go and you grab the other thing and you walk away. So you just responded to the cause, which is a need to manipulate something with their hands. So that's just a simple.
It's like distraction, like you're trying to distract.
It's a distraction, but it's a distraction, but you're also intervening. It's a strategy. You're also giving him something to occupy himself. I'll give you another example. A patient who is always speaking of his mother. Like, I want to call my mom, I want to call my mom, I want to call my mother, I want to call my mother. But the mother is deceased, right? A lot of people are very uncomfortable with that. And it's like, oh, we'll call her later. We'll call her in 15 minutes. What they don't realize is although the person has dementia, Normally, deep down inside, they know their parent is deceased, but it's very abstract. So they can't say the words. But what they do know is that they miss them. So it's a lot better for the caregiver to say, you know, you look like you really miss your mom. Are you sad? So validate the emotion.
Mm-hmm.
We tend not to validate the emotions. We tend to tell them, oh, I don't like it when you cry. Can you stop crying, please? When it's a valid emotion. So you validate the emotion. I can see that you're sad today. Are you missing your mother? And then the person will probably say yes. And then you can say, can you describe her to me? Can you speak to me about her? And then they'll say it. If you have a memory book, it's even better. You can sit down with the patient, go through pictures, a memory book, and just let the validation go through, let the emotion go through, and eventually it'll pass. And then you divert to something else. Then you change the subject. You don't stay in that for a very, very long period of time, but you address, you validate, you reminisce, and then you divert to something else.
So let's say somebody all of a sudden starts displaying some aggressive behaviors or something like that. I mean, what type of like medical issues could contribute to this? And at what point should you have an evaluation done?
So it's very important to remember that a patient does not walk into his dementia. A patient does not become demented within 24 hours. It does not happen, right? However, patients with dementia do have a higher sensitivity to infections, to medical problems. So that being said, if your loved one is continent, if he knows who you are, if he's able to sit down and eat by himself, I'll give you an example. And then 24 hours later, you wake up and your father, let's say it's your father, he's urinating in the corner of the house. He sits down in front of his food and he can't seem to know what he's doing. He's a little bit more disorganized. He's not sure about who you are. This is a 24-hour change.
Mm-hmm.
Something is going on. It's not just dementia. So you need to bring him to the hospital and you shouldn't wait. And when you get to the hospital, be advocate for them.
Mm-hmm.
Because a lot of times when we walk into the hospital and we tell the people, oh, my parent has dementia. Oh, it's dementia.
Yeah.
Dementia explains everything, right? So it's very important that when you bring them to the hospital, you have a very clear description of how he was yesterday and how he was today. And do not accept, oh, well, it's the dementia. It doesn't work that way. It really does not. We have to investigate and we have to advocate for them because they really don't have a very big place in their health system. I'm sorry to say.
I agree with you 100%.
We have to advocate for them.
Yeah. So what role do medications play in terms of managing challenging behaviors? You know, like are there really the magic pill to help with all of these behaviors? Like what role does medication play?
So don't shoot the messenger, right? But oftentimes when the patient starts exhibiting behavioral disturbances, right away we want to have them treated. We want to have them on pills. We're going to give them medications instead of treating the actual underlying cause, which might be an unmet need. And what happens is, if you start giving these patients these types of medication, like psychotics, benzodiazepines to calm them down, what's actually happening is you're blurring them. You're blurring their cognitive functions. You're slowing them down. You're putting them at risk for more physical problems, like you're putting them at risk for falls. You're putting them at risk for disorganization, for delirium. So you have to be very careful with the medications you give because the antipsychotic drugs have very limited effect on behaviors. So if you're looking to treat the wandering, medications doesn't really work on that. If you're looking to treat the screaming, the need to go home, the fact that they have anxiety, it doesn't really work on that because that cause will always stay. It's something that's inside of them. It's not something that you give a pill and it goes away. However, if your patient does start having hallucinations, very severe anxiety, where he has insomnia, where he doesn't sleep all night, then you could have a consult with the doctor and you could ask, for an evaluation of these symptoms that could be treated with these medications. But at the same time, you really need to evaluate and you need to have an eye on your patients to make sure that they're not having side effects. There are a lot of side effects to these medications, and the side effects can be very disturbing to the patients. So you have akathisia, and akathisia is it's called I can't stop to move. So sometimes we have patients come over the Molivine that are extremely agitated and they move and they wander, but they actually have akathisia. They have a side effect to the medication that we're giving them to stop moving. We're making them move more. You can have dyskinesia, which is very disturbing to the patients. You can have dystonia. So you have cramping, you have muscle spasms, they start jumping. They have, if you can imagine, if you've ever had whiplash where your neck hurts because you're bent over, the medications will make them bend over and it'll give them cramping in their backs, even in their throats. They'll sometimes stop eating because they can't even swallow because of the medications. So we have to be so careful with these medications. We have to work on the causes. Once we've looked at the causes, once we've looked at non-pharmaceutical interventions, then we can maybe think about having pharmaceutical interventions, especially if it's light to moderate. It should be the last line.
And I think what we had spoken about previously is really understanding the person's life story, who they are, understanding their triggers, what makes them happy, what doesn't make them happy, which would hopefully prevent some of these behaviors from occurring. So it's really about that life story. I'm just going to skip ahead a bit. I wanted to ask you, so there's still many people that are caring for somebody at home, okay? And at what point can behaviors become really dangerous? And when should a family either call 911 or bring the person to the hospital? Because that's the part I feel that people are not sure. Sometimes I'll hear families say, oh, well, they only grabbed me once or they only hit me once. So when is it when does it become too much to care for somebody at home?
I think that the caregivers, the family members need to really follow their instincts. I even tell my staff at the Molivine when I leave work during the day, I say, nobody needs to be a hero today. I tell them this all the time, right? You have to follow your instincts and you have to remember that you're not alone. And you shouldn't think that you're alone in taking care of your loved one. If you feel that your loved one is dangerous, that he's a danger for himself, that he's a danger for you, you need to call 911. You need to step away from the situation. You need to go in another room if you have to until they arrive, because it could be very dangerous for you. You don't know. He could be in a delirium. He could have an infection like we spoke about earlier, right? Where he's not capable. He's not capable of controlling his impulses or his behaviors, and he could be dangerous. And it could just be an infection. So it could be very passager. It could be very temporary. Right? So you really need to take care of yourself and your own security, because you're not going to be any good to your spouse or to your parent if you're in a hospital yourself because you were hurt in a situation. So that's one scenario. Another scenario could be that he's getting aggressive and you're the trigger, but you don't think that he's going to hit you. He doesn't seem to be displacing furniture. He's not hitting walls. He's not threatening to hurt you. So I think that one of the things to do in a situation like that is not to call 911 just yet. However, what you should do is you should go close to your loved one and you need to validate his emotion. I see that you're really angry right now. I think that you're angry at me. I love you. I'm going to go step in another room right now. I'm not going far. I'm not leaving the house. I'm just going to go step in another room because we both need to calm down. So I'm going to go calm down. You'll calm down and I'll come back in a few minutes. I love you. I'm not leaving you. But I think that we just need to take a break right now. You step away from the situation and you wait. You let the cycle of stress and anxiety calm itself down. It's just like us. If we get really upset in a situation or if we get really angry, we wouldn't even expect from ourselves to calm down within a minute. We need sometimes half a day just to calm down.
Yeah, I think what you say is very important, especially, about validating their feelings, like validating their emotions, because where I've seen in my work the escalation happen is that, so you've got that verbal communication where it starts to get more heated, and then the care partner is the trigger because they don't know how to handle it. They're getting frustrated, they're getting angry,
Yep.
and then all of a sudden they get, they just explode, right? And then that's where the physical comes in, where I've heard of, like, a spouse throwing a remote control at them, or
Yep.
grabbing a pair of scissors and saying, "I want to kill you," or like, it's just because it's really escalated. And I think that, like, what you're putting your focus on is those communication skills are so important at that moment, right? To validate what's going on and take that break.
And it comes back to the cause. It comes back to the cause, because even if you can't figure out what the cause is right there and then, don't act on the behavior, right? Because what's happening is, as you said, people will argue with people with dementia. Don't argue with somebody with dementia. You're not going to get anywhere. And you need to ask yourself the question, what are you trying to convince them of? What argument are you trying to win? Because you're not going to win the argument, right?
That's what I always say. I always say, dementia is like the devil that is sitting on the person's shoulders and telling that person what to say. Because it's when you're talking to the person who has the disease, you're not talking to the person, you're talking to the disease. And unfortunately, the disease wants to provoke, right?
Yeah.
All the time. So it's very, very challenging. And especially, I think, for spouses to just say, okay, I need to walk away.
I see. The thing is that I'm not sure that I would say that the disease wants to provoke, but what I would be willing to say is that we need to remember that they're not trying to give us a hard time.
Yeah.
They are going through a hard time.
Exactly.
And that's the difference that we have to make. And so when we see that they become agitated, when we see that they're upset, they have every right to be upset. They have every right to be agitated. They're forgetting who you are. They're forgetting their environment. They're feeling confused, And so we need to step back and understand that they're going through a hard time. And when somebody goes through a hard time, you don't attack them and step on their heads.
Mm-hmm.
You need, and with all due respect, caregivers' jobs is the hardest job in the world. There is no harder job than being a caregiver for an adult, somebody that you love, that has dementia. It is emotional, it is physical, it is trying, and we all make mistakes, all of us. But what's important is to step back and to reflect. What happened? So what happened? What could I have done differently? What can I try tomorrow? Tomorrow's another day. We'll go to bed, we'll wake up. Tomorrow's another day.
So I have time for two more questions with you. So
because you sent me a lot of questions.
I sent you a lot of questions, but what's great is that you've answered a lot of, like, you've answered almost all of them in your responses. How can we create a safe and supportive environment for a person with dementia? Like, are there specific modifications, or like I know how important routine is for a lot of people, right?
Yeah.
But how for those people that are still caring for somebody at home, what could we do to create a really comforting and safe environment?
So there's again, there are so many ways to address a secure environment for somebody with dementia. So we have to look at the risk factors. So you have to cut down the risks. So is there a risk of fall? So if you want to adapt the environment for a patient who's at risk of fall, then you have to make sure to unclutter your household, to make sure you have a lidded environment, to make sure that you don't have any rugs all over the place. You have to make sure that the bathroom is well equipped so that the patient doesn't fall, because all of these risks are triggers. If he goes to the bathroom and he's afraid to fall in the bath, that may cause anxiety and a behavior. If he's walking around and he's afraid to trip over something because there's clutter everywhere, there's too much stimuli that can cause anxiety, that can create a behavior, right? So there's so many things that can create behaviors in our environment. For example, the kitchen. If you want them to feel more autonomous, you can put like little plastic nudges on equipment that have automatic power buttons, so that not only do they see it, but they can feel it. There'll be a sensory. You can have there's so much. This is like almost an hour just.
Oh no, that's yeah.
There's so much that you can do to create an environment that's helpful for, and again, you have to be careful because you don't want to use too much stimuli. For example, if you're in the bathroom and you want to use a pictogram, you don't want to have 20 images on a pictogram because that's too much for them. It's going to confuse them. It's going to agitate them because they want to do it, but they can't do it because there's just too much. So there should be a pictogram with maybe 2, 3 images, very simple, very clear. The door. So look at there's a risk of flight. So like I said, just go through the risks. Risk of flight. So what should you do? Camouflage the door, hide the keys, put a bell on the key, on the door, so that if he does open the door, it'll ring. It'll tell you that he's leaving, right? You can put a watch with a GPS. There is so many things that you can do in order to protect the patient in his environment. If you want him to be more incontinent at night, put a night light in the bathroom. Change your seat to the toilet bowl for it to be black so that they see the seat. So again, you have to break down the risks. What are the risks? Risk of flight, risk of fall, risk of denutrition, risk of incontinence, risk, and then you work around the risks. Does that make sense?
No, 100%. And I think one other question I also wanted to ask before I asked you the last one was, so as the disease evolves, I mean, I know the answer to this, but I want you to answer it. Do the behaviors change? So let's say we know that there's different stages of behaviors, but a lot of times people say to me, "Oh my God, how long is this behavior going to last? How long is they're going to call me 50 times a day?" But as it evolves, do many of the behaviors like disappear or change?
Of course. It's like a wave. The behaviors can change. Usually it's about a 3-month, they say about a 90-day process. And sometimes another behavior will come around. But usually there is a light at the end of the tunnel. Usually the behaviors will stop and they will change. Hopefully they get better. Hopefully.
Well, I think also as the person really begins to lose their communication skills more and more, and they unfortunately become less mobile and they become more docile.
You have to be careful, however, because I would say that the patients that I have the most aggressive behaviors with are the ones that lose their words.
Because they can't express their emotions.
Exactly. And we tend to, I don't understand what you're saying. Don't you remember? And so even the way that we speak to them, even the things that we say, we refer to their memory. We refer to the fact that they can't do it anymore. Don't you know you can't do that anymore? And so we have to stop doing that. We have to stop referring to memory. We have to stop speaking about how we don't understand what they're saying and we don't know what they want. And it makes them more agitated and it makes them frustrated. Because the very most important thing that most people have is being able to communicate, and they can't communicate. And so we have to be careful with the speech and the communication skills, and that's a whole presentation on itself too, Claire.
Absolutely.
Communication skills.
That's a whole in itself. So one last question. How can I take care of my own mental and emotional health as a caregiver?
I think that the first thing that you need to do is you need to get yourself a very good support system as soon as you have the diagnostic. And that is probably the best way that eventually you'll be able to take care of yourself. Most people wait way too long. They wait until we're moderate into the dementia, until they start feeling like they're tired and they're going through a bit of a burnout. But it's already too late, because then you're too tired to ask for help. It takes a lot of energy to organize. So it's always better to start at the beginning. As soon as you have a dementia diagnostic, you should be working on a treatment plan. And you could actually be working on it with your loved one. So you should be, from that moment, getting a good support network. Accept the help. Accept the resources. Involve your family members. Give them the opportunity. If we're going to break the silos, and if we're going to break the stigma that surrounds dementia, we have to stop hiding our dementia patients from their family, from their grandchildren, right? Because Clara, I don't know, but we're the same. I'm not going to say how old we are.
We're the same age.
You know, but on Sundays, we had to go to grandma's.
Yeah.
We had to go eat at our grandparents'. And so we have this internal need to take care of our elders. And we're losing that with the new generations that are coming. We have to give them that gift, the gift of taking care of elders, the gift of being involved, doing some volunteer work, walking with them, talking to them, reading to them, to give the caregiver some respite. Just that respite is going to be help for their mental health. To ask for help, to get the society, la Société des Alzheimer, go get l'appui, go get resources. But they got to do it. They got to do it before the storm hits. They have to precede the storm. They have to be ready.
Well, I was one of those caregivers who had the burnout, and it took a burnout for me to finally ask for help. And what I hear all the time from others is always like, many thanks, but we're not there yet. I'm not there yet, right? But oftentimes it takes a crisis to occur before you finally get the help that you need. And you should.
Unfortunately, most of the times that we get asked for consults at the memory clinic is usually for crisis. Most of the phone calls are crises. I mean, people wait too long, and they want to take on taking care of their loved one, and I understand that. But you have to take care of the relationship with your loved one as well, and you can't do that if you're doing all of the care around them. So if you're able to surround yourself with resources, there's a lot of resources out there that offer help. That way, you can take time for yourself. And some of the time that you have with your loved one is actually quality time. And that's what's going to make it a lot easier on you. Be prepared, be informed, get as much knowledge as possible, and understand what dementia is. Because a lot of people, they know the word dementia, but they don't understand what dementia actually is. What are we talking about when we're talking about cognitive spheres? What are we talking about when we're saying we have cognitive dysfunction, so that they understand what's going on in their loved ones' heads?
And that's why we developed this book, because it actually has a lot of information. Carmen, I'd like to thank you so much for taking the time to be with us today. And it's very exciting because this year, the Dementia Education Program will be working with you and your team at the Douglas to develop video capsules. And we will really be zoning in on communication skills and really these mini capsules. So the viewers should just stay tuned. We'll be developing it this year. And you'll be seeing many more videos with Carmen in it. So thank you so much for taking the time. This webcast is an initiative of the McGill University Dementia Education Program, which is funded by private donations. If you would like to make a contribution to our program or for more information, please visit us at mcgill.ca/dementia. And if you'd like to join our mailing list to be notified about upcoming episodes of McGill Cares, as well as other important programs, please sign up for our newsletter. You can also email us at dementia@mcgill.ca. Thank you for watching.
Thank you.